are on mute. Please use the chat for any questions. If for some reason you are unable to use the chat feature, then please click the hand raised icon and you will be unmuted so you can ask a question. If you have audio or visual issues, we ask that you log out and log back in. If you are looking for CEUs from the NASW for this session, please type your name into the chat at this time with the word CEU sign in. And then when the session concludes, if you could also sign out by typing your name again with the word CEU sign out. Just as a reminder, like all sessions we've had at the summit, this session will be recorded, I believe, as well as the chat, and everything will be put on the website after the fact in a few days. So I am your moderator, Allison Green from MICAH. We have two presenters today. We have Lynn Hedges from the Michigan Department of Health and Human Services and Katie Heisberg from the Michigan Coalition Against Homelessness. So I am going to let her start sharing. I wanted to let you know that we will be taking questions at the end of the session. So feel free to type in your questions as they come up, but then I will read them to our presenters after their presentation is over. Thank you. Take it away, Katie. You're still muted. Katie, if you're talking, you're still muted.
I was kicked out. Can you see and hear me now?
I can see you and hear you.
Okay, 1 second then. Okay, can you see the slides okay?
Yep.
All right, take it away, Lynn.
Thanks. Good afternoon, everybody. My name is Lynn Hedges with MDHHS Housing and Homeless Services. Thanks for joining Katie and I and Allison today. We're excited about the opportunity to share with you some information and lessons learned about a project that we've been working on actually for the last 4 years in different iterations, and one that keeps evolving, and we're excited and hopeful that in the future this might be something that many more communities might be interested in participating in. Can I have the first slide? Thank you. So what does housing have to do with healthcare? So about 4 years ago, MDHHS, MICAH, MSHTA, and a whole host of other partners across the state participated in what was known as the State Innovation Model, or SIM. And SIM had already been operating in 5 communities, the Northwest Michigan 11 county region, Muskegon, Washtenaw, Jackson, and Genesee counties. And SIM was at the time was really focused on improving health outcomes. And through their community assessments, they found that housing was a critical need in their communities. And so we stepped in to kind of expand the scope of SIM and start looking at ways that housing and healthcare overlapped, and how helping people get housing actually improved their health outcomes. So housing is what's known as a social determinant of health, or an SDOH. You probably heard that quite a bit in the last couple of years, as many state and federal agencies have been, and private healthcare has been really interested in social determinants of health. And SDOHs are really fundamental to people's overall well-being. So if the goal is to help people stay healthy, or get healthy, or to have a good quality of life, they've been able to really point everything back to those social determinants of health. In my opinion, the most important one, if not, one of the most important ones. Homelessness exacerbates illness. That's probably not a surprise to anybody, but if you are homeless, it's extremely difficult to take care of your physical and mental health. And so as a result, if you have underlying health conditions or chronic health conditions and you are dealing with homelessness, your health is not going to be great. On the flip side, housing provides safety and protection, which we've seen very clearly through this COVID pandemic, staying at home, isolating, quarantining. Housing provides that safety and that protection, and is really fundamental to a person's health and well-being. So helping solve homelessness and helping end homelessness isn't a problem that only the homeless response system can solve. And that became really clear as we continued to go through the SIM project, is that it's a collaborative experience, and it takes all of us. We can provide certain things. We can provide housing resources, or we can provide shelter, or we can provide financial assistance. But there's so many other things that also go into helping individuals to end their homelessness and then to stay permanently housed, that it's not just for us to solve. And we found great partners in our healthcare sector to be able to explore how to do this. And then we each needed help understanding and communicating in each other's sectors. So this was probably one of the most poignant learning components of SIM Health Through Housing, and that is when you get two really large systems in a room, you have to create some shared language. Healthcare, we both have the same intentions of taking care of people. The homeless response system's intent is to help people get housed. The healthcare sector's intent is to help people get healthy and stay healthy. But we go about it in very different ways, and we talk about it in very different ways. And so fundamentally, the very first thing that a lot of our communities had to do was get in the same room and start to figure out what that shared language was and what the shared goals were and how they could kind of meet both sides' needs, and in order to be able to accomplish what they were hoping to accomplish. So it actually was very successful, and once we figured out the communication issues, things really started to pick up. Next slide, please. So as I said, the state innovation model was actually something that came out of Medicaid. We had been participating in it, it recently came to a conclusion after more than 3 years. There were 5 locations that we were working with: Washtenaw County, Genesee, Jackson, Muskegon, and Northwest Michigan. And there were 4 specific housing initiatives. The first was the data match between HMIS and Medicaid expenditure and utilization data. The second was our frequent user pilot. The third was improving the homeless response system. And the fourth was our Medicaid waiver or Medicaid billing for housing supports. And I'll go really quickly just into a brief overview of those. I'm going to talk mostly today about the data match, but I do want to touch on the other 3 initiatives because each of them had some great successes and some really interesting outcomes that are important, I think, to the overall conversation. And I do want to say that this project really took a phenomenal team of people in order to get this done. It consisted of several folks within MDHHS. We had great support from Micah with the data. We had wonderful support through MISHDA, through their housing vouchers, as well as all of our community-based agencies who participated both on the healthcare side and the homeless response side. So there are a lot of people involved in this project and a lot of organizations that really came together in order to make this work. The frequent user pilot, I'm just going to touch on really fast. We had 3 communities of the 5, Northwest Michigan, Muskegon, and Washtenaw, participate in a frequent user pilot. And what that was we paired supportive service dollars with a MISHA HCV for a local, one of those or each of those 3 communities to be able to identify high utilizers or frequent utilizers of Medicaid services and help those agencies to be able to create essentially a permanent supportive housing environment to be able, and then we tracked their utilization and expenditures post permanent housing. That just recently came to an end at the end of fiscal year 20, and we are waiting for the final evaluation of that project, but we've been really encouraged. Some of the things that we saw in that pilot were not just positive expenditure or utilization improvements, but we really saw improvements in people's quality of life. Some people were definitely chronically ill and had very expensive chronic health conditions that weren't going to go away, even with housing, but their quality of life post-housing was significantly improved, and they are now safe and stable, and that's a pretty phenomenal outcome. Second, the improving the homeless response system. Oh, the thing about the frequent user pilot too that I just want to touch on really fast is really in some ways kind of an incubator. It was a pilot to see how the impact of these supportive services and housing was directly on utilization and costs and overall health. And our hope is that what we've learned from that pilot, we can share with other communities and other COCs across the state to help them and encourage them to consider doing their own frequent user pilots. Ours was focused specifically on Medicaid, but there are other communities right now that are looking at things like utilization data through law enforcement. They're looking at data or have taken data directly from the hospitals with ER visits. So there's lots of different ways that this can be done, and there's lots of different ways to prioritize populations that are really vulnerable, that need that kind of housing assistance. So we're really looking forward to being able to share what we've learned, and what's come out of the pilot was the data match that we're going to talk about in just a minute. I do want to also just really quickly talk about improving the homeless response system. In all 5 of the SIM communities, we were able to provide grants to those communities to be able to develop their own local strategies on how they could improve the homeless response system in cooperation between the healthcare system and the homeless response system. And what our communities were able to do was really astounding. It was everything from some pretty sophisticated process mapping that was able to show handoffs between the HARA, the hospital system, and substance abuse treatment facilities, and where individuals sometimes fell through the cracks and how to resolve those. There was really phenomenal assessments done on housing availability and what the needs are in their communities and the specific kinds of housing that those communities need. And there was work on diversion. In the several last sessions, you probably heard some referencing to shelter diversion and the effectiveness of shelter diversion in several communities. And that was also one of the topics that was done and trained on in the Improving the Homeless Response System work. So it was a great opportunity to be able to broaden the communication and the coordination outside of just the COC, but to be able to go into the healthcare system or your education system and such, and really build stronger relationships and stronger mechanisms for being able to coordinate services. So we were thrilled about that. And then the last thing was we worked for several years with our colleagues in Behavioral Health and Developmental Disabilities Administration in MDHHS to get a Medicaid waiver passed within the behavioral health carve-out that allows Medicaid billable agencies to bill for tenant support services. We did finally get approval for that, which is exciting. And we have been trying to figure out how to put that into place and then how to help our providers who are delivering housing case management services to subcontract with those CMHs to be able to access that funding. Okay, so now I'm going to get to the meat of our session about the data match. Katie, can you forward it? Thank you. Okay, so the data match. With a lot of amazing support from Micah, we, and when I say we, I mean mostly our phenomenal technical staff at MDHHS, were able to develop a mechanism for being able to match HMIS data of active clients against actively enrolled Medicaid individuals and see what the overlap was. So how many people who were actively enrolled in Medicaid were also currently homeless. And the data has definitely told us some important information. It's told us a lot of that. First and foremost, we do have a relatively high match rate, which is great, which means that individuals who are experiencing homelessness are enrolled in Medicaid, which means they have access to healthcare, which is that's good news. There is a gap between those who are homeless and are not enrolled, and we are looking at strategies for how we close that gap. How do we identify those individuals who are not actively enrolled or who may have, or whose enrollment may have lapsed, so that we can make sure that people have access to healthcare. The other thing that we learned about through the data match is that these two systems can work together to eliminate barriers. And we may not know when people are very sick or need a lot of care. And what I mean by that is there were several instances during the data match process where where communities identified people who were very sick, but for whatever reason hadn't accessed the homeless response system, or who had accessed the homeless response system, but they didn't realize the extent of their chronic illness. So it provided a lot of good additional information to be able to allow our HARAs to be able to, and our prioritization committees within our COCs, to be able to make really good decisions about prioritizing for resources. And housing may be the catalyst. I can't stress enough that helping individuals and families get into housing may be just what they need to help their health, whether that's just the stability of housing, whether that is the ability to be able to start regularly going to doctor's appointments or seeing providers, or getting on a routine, or helping with their diet, or taking their medications on a routine. Housing really could be the catalyst to much better healthier outcomes. And it could be the one thing that helps a person to be able to recover from a longstanding illness that they could recover from. There were situations where individuals had things that had health issues that just had not been dealt with for years. And as soon as they were able to get into housing, they were able to take care of those health conditions and they were resolved, which is phenomenal. It means the person doesn't have to live constantly in pain. So housing really can be the catalyst to good health outcomes. And then be inquisitive and don't give up. Learn from what worked and what didn't. And it's that term, fail forward. This process has not been an easy one because as much as we've learned along the way, we've also learned a lot of things not to do along the way, or things that we thought were going to work out and just didn't give us the results that we had expected. So it really is important, as we continue to do this matching and we continue to learn more about the data sets, that we ask a lot of questions. One of the things that we've been doing lately, as we have been working with some additional COCs on frequent user lists, is we've been asking for a lot of feedback about what they're seeing in those lists. How's the quality of the data? Do these people align with what you thought they were? And we've gotten just a rich amount of feedback from those COCs back to us to help us better tailor our criteria, to make sure that we're getting the right people on those, that we're really targeting the right people, or that we haven't missed a criteria, or that we haven't somehow left something out in our queries. So that conversation back and forth continuously is incredibly important, and it's rich and it's valuable, and it helps us every single time we do a match because it just improves the process that much more. Next. So what are we still working on? We still have a lot to do. It's hard to believe that we've been at this for 4 years, and because we still have a long way to go, and there's a lot that we want to do. And we feel like we have just started to build this great foundation to be able to keep moving forward. So we were able to do a routine monthly match between the state Medicaid data warehouse and an exported file of HMIS data. And what we are able to do with that is to be able to identify, like I said, the people who are actively enrolled in Medicaid and active in HMIS. And then from there, we're able to create frequent user lists of individuals based on their utilization of Medicaid. So that could be frequent inpatient utilization, that could be emergency department visits, that could be expenditures, that could be any number of criteria. But now we have a process in place that allows us to do this on a routine basis and have really relatively current data, which we can then help to share with the COCs to be able to help them in their prioritization process locally. Next. The next thing that we are working on is we received some funding from the Health Endowment grant to create what we're calling a risk score. One of the things that we had been tossing around is we've had conversations with the Medicaid health plans about because they're very interested as well in identifying who their subscribers are who are currently needing housing assistance. And so figuring out a mechanism in which we can partner our homeless response system with Medicaid health plans, community outreach workers in order to better serve clients who are homeless was a real, that's a big goal for us. One of the ways that we're trying to accomplish this is by creating a risk score. So healthcare data and HMIS data is extremely sensitive. Everybody knows that. And we take the privacy issues around this data extremely seriously. And we want to make sure that we continue to protect that information at all cost. At the same time, we want to find a way that we can share information safely that provides some indication as to if a person has a high level of vulnerabilities or healthcare needs. And so what we are exploring is this concept of a risk score. And that would be created through an algorithm that would take into consideration a multitude of different criteria and essentially create something very simple, like could be like a stoplight. It could be red, yellow, green. If you're red, that means you have a high level of needs, whether that, and again, that could be a whole list of different criteria, from your housing needs to your healthcare needs, to other social determinants of health. Again, we're trying to make sure that we're masking the individual information and the individual data as much as possible, to protect the privacy of the individual while still flagging that person as having high needs for the service providers, so they know that they need to take extra steps to be able to work with this individual and help get them the assistance that they need. And it's really one more tool in the toolbox. It's really meant to just augment existing assessment and triaging that's taking place. But it's additional information that helps to inform the case managers who are actually working individually with the person who needs assistance or the family. And it's really, again, about fostering greater collaboration too between healthcare and homelessness and our homeless response. Next. So what else is next? We are going to do further automating of the match. We're looking to expand our reporting capabilities of frequent utilizers to the COCs, to more COCs. We're currently working with 1, 2, 3, 4. We have 4 COCs right now that we've worked with, in addition to the 3 that we were working with on our pilot. And we do have some capability to work with even more COCs. We want to do additional and more extensive analysis because we want to know more about this population. Like I said, we want to know what the gap is as far as the individuals who are not actively enrolled in Medicaid, and how we can work with other parts of my department, MDHHS, to help get those individuals enrolled. We want to be able to help seniors. Obviously, our senior population, homeless population, is growing. We want to make sure that we are helping to get our seniors in touch with critical needs and assistance. And so there's lots of opportunity there. And then risk score implementation, we are continuing to work on that. And then matching with other data sets. This has given us a great opportunity to, as a proof of concept that this idea works. And there are other opportunities for us to match HMIS with other data sets that could be really informative and helpful for both our homeless response system and also and some of our partners, other human service partners. So we are looking into that as well. And I think that might be my last one. Is that it? Yep. Okay. So I'm going to turn it over to Katie, who has been an absolutely phenomenal partner. She and Jerry Leslie in helping us with the technical components of the privacy components of doing this, of the data use agreements, the security agreements, and definitely all of the technical nuts and bolts to actually make this happen. So she is a miracle worker, and she will be able to get into the more specifics of this process.
Thanks, Lynn. So I guess we can just open it up for questions now. Specifically, I can help with more technical stuff. If there's anything you'd like to address out of this project, I would like to say up front, kind of echoing what Lynn has stated earlier, that if you're looking to take on something like this, it's kind of like when you're a kid and you're doing like a maze in an activity book or something, and you come to the realization one day, either somebody tells you or you figure it out, you start at the end of the maze and then work backwards. It's a lot easier. So I feel like that applies to most any large project that you want to take on. So, look at where you want to end up and then move back incrementally in your planning through various phases. And you'll probably find once you get through or start on phase 1 of your project, phases 2 and 3 can change entirely. But I would say plan as much as you can and build as strong of a communication link as possible.
Okay, we do have one question in the chat so far. So it says, do we have any ideas on how much in Medicaid payments have been made because of these connections to the nonprofits?
So I hope I'm understanding the question right. We don't have a total dollar amount as far as how much it has been spent on the total homeless population. But one of the things that we are trying to do is we're trying to compare utilization or expenditures for individuals who are homeless against the general Medicaid population. To see if they are in line or if there's any kind of derivation from if there's anything that may be more utilized with the homeless population or less utilized with the homeless population when it comes to both cost and sort of overall health conditions, like number of chronic health conditions or the utilization of emergency room visits or inpatient stays. So we're trying to compare that to the general population as sort of a one method of seeing if there's anything different or specific about our population.
Okay, that's the only question we have so far, so we'll give folks a minute to see if they have any more questions that they can put in the chat. Okay, we have another one that says, how will you recruit or decide on additional communities to become involved in the frequent user pilot?
Our frequent user pilot has actually come to a close. Our funding ended the end of fiscal year 20, so September 30th of this year. So we aren't going to be able to continue the frequent user pilot. But what we are able to do is if a community is interested in starting one themselves locally, or if they're interested in using frequent user data in their prioritization process, we are able to provide that to the COC to help them with that process. And that's open to any COC in the state. We work collaboratively with Micah on that process. So they're welcome to reach out to me and Henges L2 at michigan.gov and or Katie, and we'd be happy to set up a time to talk and can talk you through the process and get that set up for you.
We have a, oh, yep.
Oh, you can go ahead. It might be something I thought of. So.
We have another that's a comment more than a question from Amanda from Han that says, one outcome we've seen as PSH providers bill more services to Medicaid is that if their current staff do not have the appropriate licensure, this can lead to staff turnover and the loss of otherwise qualified housing support staff. As we think through how to better leverage Medicaid resources in our community, this is something we will need to be mindful of and plan for.
Mm-hmm. Yep, absolutely, Amanda, you're right. Thank you.
And then another comment says, this is exciting work. I have been of over 20 years that housing has a direct correlation to health determinants. Great work.
Thank you very much.
So the comment that I wanted to add was more of a data specific lesson learned. If you are COC looking to participate in this or any other data matching sort of project, you're going to find out really quickly some key things about your data if you have areas with poor data quality. So one community in particular had a very low match rate at first, I think compared to some of the others. And we found that a lot of the clients were missing full Social Security numbers. And what I found through various data warehouse projects at this point is they can't match on partials. We've tried, and we've tried to make it a point that, you know, the last four is the most unique part of a client you know, information. If they had that and the date of birth and the full name, you should be able to match on all. But if that full Social Security number isn't in there, you're not going to get a good match rate. So we found that out. So it's important to always get the full name, full date of birth, and full Social Security number, and ensure that those are all correct for that to work appropriately.
We had a couple more things come in. So the first one is there an opportunity to join into any of the housing initiatives to address issues in our area, such as discharging from health systems to the streets?
Yes, we would love to talk with you. And because a couple of our communities had done their improving the homeless response system work around discharge planning, we would be more than happy to connect you to them. And there's some great new practices that are going on. So please reach out to me if you could, or I can grab your information from the chat, and would be happy to talk with you more.
And then another comment we have states that Amanda makes an excellent point. They're a SOAR practitioner who is grant funded and have been considering going back to school to add an MSW to their MBA in order for their agency to be able to bill Medicaid for her homeless or his or her homeless support case management. So I'm less grant reliant. I'm not thrilled to go back to school, but options seem limited.
Mm-hmm. Yeah, definitely one of the challenges of Medicaid is the credentialing, big hurdle.
So we'll give folks another couple minutes in case they want to add any other questions. If not, you can submit, questions to us after, and we can get them to the presenters to answer for you. And to remind you, this will be posted on the Campaign to End Homelessness website after the conference is over. We have a question that states, where might we get funding to supplement any of these initiatives should we decide to take them up?
That's a good question. I think there's a couple of opportunities that you might want to explore through if you have a health plan in your community that has a particular interest in this issue, that might be an opportunity for some funding. Different philanthropic organizations like the Health Endowment Fund that have an interest towards social determinants of health, I think are also good places to inquire. I would say those would be my first two. Community, some of your community health related foundations or hospital systems with any of their community benefit funds may also be interested in taking on something like this. I would start on the health side and explore local providers, local opportunities, local services there first, and see if you can find some willing partners that might be willing to put up some funding too.
That's the end of the questions for now, so we'll give it another couple moments for if folks have any other questions that they would like to ask our presenters.
I would just add that it's always exciting and somewhat terrifying doing something that's not been done before. And even if you're doing it, if you choose to do something like this locally, one of the best things you can have is a good, strong partner at your side who's willing to really work through the process and work through those challenges. I know for a fact that if it weren't for our partnerships with Micah and Mishta, I mean, they were fundamental to making this happen, as well as we got some federal TA through Medicaid. We had an innovation project through them that was helpful, and the feedback from our local partners, and having our local partners willing to take that on as a pilot. That was not an easy commitment for them to make. Brand new idea, brand new project. We were lucky that we had a partner in Washtenaw with Avalon Housing who had done a frequent user pilot previously. But it was still all new, and I want to give a ton of credit to our local providers as well for taking that on, because it was a new challenge, and we didn't know what we were expecting, and we didn't know what was going to happen. So having good partners by your side is definitely is a must when you take on new projects like this. But what we were able to learn on the back end from doing all of this has been, I think, incredibly helpful, and also has, I think, both locally and then also at the state level, has been able to give us so much insight into, as we have further conversations about the integration of housing and healthcare, and the importance of making sure that so many of our programs that we offer at MDHHS are keenly aware of the needs of the homeless population and how to serve them better.
Another question came in that states, what were the main differences between the rural and urban responses?
In the frequent user pilot or in the improving the homeless response system? I would say if I'm talking about the frequent user pilot, we didn't have really an urban participant in that. We had sort of smaller or maybe smaller suburban participants with Ann Arbor and Muskegon, and then but all of those counties that participated have rural areas to their geographic coverage. I would say each of them experienced challenges with affordable housing. The Northwest region struggled so much with a lack of affordable housing because they are in, the hub of that region is Traverse City, and that is such a tourist-driven area, and it's such an expensive area. So I know that they struggled greatly with being able to find affordable units for their frequent users. And with most, the challenges were similar as to other rural communities. Transportation is a huge barrier. So if you find housing, it might be 30, 40 minutes at least or more away from all of the basic services, and with no real easy transportation to be able to get people back and forth, that doesn't really help very much. So I would say in our rural communities that those two things were definitely a big challenge. Finding affordable and available in a community that was, that everybody wants to live in, where is just so incredibly overheated. And then if you do find available housing, the proximity, the distance to services was just so great that it became a real barrier to helping people be able to access those services.
We have another question that came in stating, could you address the culture of the health sector and how homeless providers might improve our ability to work with them?
Oh, I'd love to. Thank you. That's a great question. And this is from my perspective of sort of seeing it from a global view versus my colleagues who are the providers, the homeless response providers on the ground, and interacting with their healthcare systems locally. But I can tell you, based on their feedback and what we've learned from the project, is that the healthcare system is, to say it's complex is probably an understatement. It is huge and multifaceted and extremely complex. And there are lots and lots of different parts and pieces to it. Your health department operates very differently than maybe your hospital system. They have different focuses, they have different goals, they have different priority populations. Your Medicaid health plans have their own community health workers, for instance, and are working with their enrollees, but they're a completely different entity than your local hospital system. What I would say is the best first is to understand that it will probably take time to get to the right people, and start small. I would say one of the best things you could do is start small. And I go back to some of the great work that they did up in Northwest Michigan with their improving the homeless response system. they were able to build a really good partnership with a hospital in Cadillac, which is a smaller community than obviously where their population hub is in Traverse City. It's Munson Cadillac instead of Munson Traverse City, and that's where they found people who were really willing and able to sit down and talk through it and work on these processes. And my understanding is that that led to opening other doors in other places to be able to build on those relationships with other healthcare sectors. The local health departments have been really phenomenal partners. The FQHCs have been phenomenal partners. And yesterday we had a session with my colleague Shane Bies from Oakland County Health Department and Elizabeth Kelly from Hope, and which is a shelter in Pontiac. And one of the things he really stressed was, no pun intended, was that health systems are really, really stressed right now, as are we. And to give them some grace and understanding and continue to reach out, continue to build the communication bridges, try and find those that common language, that know that they are under the gun to meet certain goals and outcomes and measurements that they have to, just as we have ours, and figure out how can we meet in the middle, and there are things that their systems are able to do that could really be beneficial to us in our work, and there's a lot of things that we do that can be really beneficial to them as well, that they may or may not know. So lots of communication, lots of education, and probably breaking it down into the real simple steps. Sometimes you got to break it way down to when this person walks in the door, I pick up the phone and I call Katie, and Katie does her work, and then Katie has to call Allison, and then Allison does her work, and then she calls Lynn back so that Lynn can complete the job. Sometimes it really has to be that simple, so that everybody knows kind of what each person is doing or what each part of the process is doing. That seemed to be incredibly useful up north, and that seemed to be, and having that shared understanding seemed to really be effective in helping the health systems to understand what our homeless response systems were capable of, and what kind of things we could offer, and then kind of the limits of the system as well. And the great thing is that they also have contacts and resources that maybe we don't know of, that they can also help to reach out to bring into the conversation.
Okay, we'll give folks one more opportunity to list some questions in the chat before we conclude. Okay, there doesn't seem to be any questions at this time. So I am going to share my screen and thank all of you for attending this session and this year's summit in general. It was our first virtual one, so I hope that you found it enjoyable and accessible. Make sure that you fill out the post-event survey that you'll receive in a few days. That really helps the planning team figure out how to move forward with the next year's summit. And I would like to also thank our presenters for SIMtastic. They did a simply fantastic job presenting.
Thank you,
And-
Allison. Thank you,
Yep.
Katie.
Thank you both.
And if you have any questions, you can definitely reach out. Otherwise, we appreciate your attendance and thank you so much for coming. Yep, sorry. Thank you, people, for remembering on their own. Sign out for your CEUs. Last call for signing up for your CEUs. I do not see that Sean has signed out. If you're still here, please type into the chat that you're signing out for your CEUs. All right, thanks again